Welcome to all of our attendees. We are going to get started momentarily as people join the session. Thank you all for coming. Okay, we're going to get started. My name is Dr. Amir Moharib. I am an infectious diseases specialist at Massachusetts General Hospital and Harvard Medical School, as well as a faculty member with the Harvard Global Health Institute. It is my pleasure to welcome you all today to our session in the Harvard Global Health Institute's Special Events Series. Today, we'll be having a panel discussion on arboviruses on the rise, and I'm honored to moderate this panel discussion. The growing threat of arboviruses is becoming ever present in our changing world. Arboviruses are viral infections that are transmitted through insects such as mosquitoes, ticks, and sandflies. This broad category of viruses actually includes many diverse infectious agents, such as yellow fever, dengue, Zika virus, chikungunya, and many, many more. These infections pose a major public health threat around the world, particularly in the tropical and subtropic regions of the world, where approximately half of the world's population lives. Meanwhile, here in the United States, we are seeing with increasing frequency arboviruses being identified, such as West Nile virus, Eastern equine encephalitis, and more. So what explains this high burden of arboviruses around the world, and how are global public health experts responding to it? I'm honored to be joined today by two experts in public health and in arboviruses who will help us discuss this important issue. First, Dr. Gabriela Paz-Bailey is the chief of the dengue branch at the Division of Vector-Borne Diseases at the U.S. Centers for Disease Control and Prevention. She is an expert in arbovirus research, in epidemiology and public health response, and she also leads the development of research infrastructure in the CDC site in Puerto Rico. Dr. Paz-Bailey has extensive expertise on dengue infection control, prevention, and response, particularly in evaluating dengue vaccines in her role as the CDC lead for the ACIP dengue vaccines work group. Joining her is Dr. Anuja Deerasinghe. She is a medical specialist in the public health at the National Dengue Control Unit in Sri Lanka. Dr. Deerasinghe is educated with an MBBS and a medical doctorate, as well as a master's in medical entomology and applied parasitology. She has over 25 years of public health experience and expertise in epidemiology, infection control, and particularly in vector-borne and neglected tropical diseases. We're going to begin today's session with a brief presentation from each speaker, and then we're going to move to a moderated discussion where we welcome audience questions for all of our expert panelists. Our session will run approximately 1 hour. So without any further delay, we're going to get started, and I'll introduce Dr. Paz-Bailey to present her introduction remarks. Thank you.
Thank you for that kind introduction, Amir, and I'm going to be sharing my slides. Okay, so as Amir was saying, my name is Gabriela Paz-Bailey, and I'm the chief of the CDC dengue branch. We're based in San Juan, Puerto Rico, and I'm very excited to talk to you today about what's going on with dengue. And I would like to start by asking why should you care about dengue? And you have probably noticed the surge in dengue coverage in the news. Really just a quick search floods you with headlines like these showing high case counts and overrun hospitals around the world. And epidemics can really strain the healthcare system with crowded waiting rooms and overrun hospitals. So While you listen to this conversation, I really want to invite you to consider what you can do from your position to help reduce dengue morbidity and mortality, because dengue is really a huge public health problem. So dengue is a disease caused by any of 4 distinct but closely related dengue viruses that are numbered 1 through 4. An infection with one virus gives lifelong immunity to that specific virus, but only short-term cross-protective immunity to the other 3 serotypes, meaning that individuals can be infected up to 4 times in their life. And dengue viruses are transmitted by Aedes mosquitoes, specifically Aedes aegypti and Aedes albopictus. Most infections are asymptomatic, about 3 in every 4 infections. And among those that are symptomatic, the early findings are non-specific, meaning that it can be difficult to distinguish dengue from other pathogens. Dengue can be life-threatening, but there are specific warning signs that will reveal the patients that are going to progress to severe disease. So for clinicians practicing and seeing dengue patients, it's important to recognize the dengue warning signs that can alert the clinician that the patient may be progressing to severe disease. So let's talk about the global burden. In 2024, WHO has received notifications of more than 13 million cases worldwide. These have come from over 103 countries and territories and include all 6 WHO regions. And furthermore, there have been more than 20 countries reporting outbreaks. And if we look at those countries and regions on a map, you can appreciate that dengue cases are occurring worldwide. However, I want to draw your attention to the Americas region, because you can see that most countries are dark blue, indicating the highest case notification rates. And I want to show you the case counts in the Americas report to PAHO from 1980, when reporting began, until last year, 2023. And we can appreciate that last year was the highest year ever in history, with more than 4.6 million cases reported until 2024. And this is the most recent data. 12 million cases have been reported already, and we're only 2/3 through the year. So I want to also tell you a little bit about the United States and where we can find dengue. So considering all US health jurisdictions, we have 6 endemic territories. And these are American Samoa, the Federated States of Micronesia, the Marshall Islands and Palau in the Pacific, and Puerto Rico and the US Virgin Islands in the Caribbean. And perhaps the area making most headlines is Puerto Rico. These are this year's case counts by EpiWeek. So the 2 lines on the bottom show the historic median in light gray and last year's case counts in light blue. The red line is the epidemic threshold, and the dark blue line shows the case counts for 2024. And we're now over that epidemic threshold for almost the entire year, which means that we are in an epidemic. And one of the possible contributors to this is that we're seeing a serotype shift from previous years to this year. This figure is showing last year's breakdown of serotypes, with dengue 1 in blue, dengue 2 in orange, and dengue 3 in yellow. And you can see that dengue 1 predominated last year, and this is consistent with dengue trends over the last decade in Puerto Rico. But for 2024, this is no longer the case. Dengue 3 has taken over as the predominant serotype, accounting for most new infections in Puerto Rico. And this is unsurprising given the lower levels of existing population immunity against dengue 3. So given these concerning trends, Puerto Rico declared a public health emergency due to the dengue outbreak earlier this year. And CDC has also activated an emergency response and issued a health alert network outlining the increases globally, but the increases in Puerto Rico and the risk for seeing more dengue also in the continental United States. And one of the main messages of the HAN, the Health Alert Network, is that for most jurisdictions in the US, the majority of reported cases are associated with travel to endemic areas. More than 94% of the cases are among travelers, unlike in Puerto Rico where dengue is endemic. And the repeated importations of dengue through travelers to areas where the mosquito is present can result in small chains of transmission or in local outbreaks. So where can we find competent dengue vectors in the US? The suitability for Aedes aegypti is shown on the left here, primarily in southern parts of the US, and then Aedes albopictus is shown on the right, extending farther north. So as we can see, competent vectors are present across much of the continental US. And historically, local transmission was only reported from Florida, Hawaii, and Texas, with that transmission manifesting as sporadic single cases or limited outbreaks. However, in the past 2 years, we have seen a concerning trend with 2 new states showing evidence of local transmission. In 2022, Arizona reported 2 locally acquired cases, and in 2023, California also reported 2 locally acquired cases, and there have been 5 reported in 2024. 1 from San Diego County and the rest from LA County. And it is not surprising that we're seeing more dengue in the US with the increase in the number of introductions due to travelers. So how can we better prepare for the increases in dengue? There are new tools that are available to prevent dengue. There are vector control tools like Wolbachia replacement that has shown really promising results. And dengue vaccines remain a quickly evolving field. In the US, we have 1 vaccine, Dengvaxia, which is available for use in endemic areas of the US for children aged 9 to 16 with laboratory evidence of previous dengue infection. And it is currently in use in Puerto Rico. Also, the Takeda vaccine has been licensed in several countries globally and recommended by WHO. And the Butantan dengue vaccine has shown high efficacy in early phase 3 trial results, which were published a couple of months ago. Unfortunately, none of these vaccines are currently licensed or recommended for use in US travelers, and Dengvaxia is only available for residents of Puerto Rico. So these are the messages that we have been sharing with our clinical partners, anticipating they will see more dengue in their clinical practice, and vaccines are not available outside Puerto Rico. So first, recognize dengue in your clinical practice, know and screen for the warning signs that predict progression to severe dengue in all suspect cases, and finally, test for dengue appropriately. I will not go into the detail of these recommendations, but there are resources that CDC has made available if you want more detail. So that's all I have for you today. I hope I have given you a high-level overview of dengue cases and what is going on both globally and in the US, and that we are seeing concerning trends with emergency responses in Puerto Rico and also activated at CDC. And lastly, these are the messages that we have been sharing with different clinical groups: recognize dengue, know the warning signs, and test appropriately. And these are some of the CDC resources. We have a newly revamped CDC Pocket Guide. So if you think you might have a dengue patient and want to get started, you can search for it, CDC Dengue Pocket Guide, and you will have it at your fingertips. And other useful resources are also noted on the slide. And that concludes my presentation. So I'm going to stop sharing, Amir, and back to you.
Well, thank you, Dr. Gabriela, that was truly a great start, and we're already seeing some questions rolling in, and I think it's going to be a great platform for discussion. I'd like to turn it over to Dr. Anoja to talk to us a little bit about dengue virus and other arboviruses in her context in Sri Lanka. Dr. Anoja, take it away.
Thank you, Amir. Good morning, good afternoon, or good evening, depending on where you are. Today, we are going to talk about a very important topic that's becoming more and more relevant. These are viral diseases with a special focus on dengue. We will also look at ways to reduce the impact of these illnesses. So this is the outline of today's presentation. Infections are caused by a group of viruses transmitted to people through the bite of infected arthropods, mainly the mosquitoes and ticks, and also through the midges or the sandflies are called arboviral diseases. The common arboviral diseases are dengue, chikungunya, and Zika. The countries and territories with current or previous transmission of chikungunya and dengue Zika viruses are shown in the figure 1. So dengue remains a challenge across all 6 WHO regions. Last year, December, WHO declared that dengue is a level 3 public health emergency, as dengue incidence has increased dramatically around the world in recent decades. There are a few key facts about dengue fever. I think Gabriela explained about dengue virus. It has 4 serotypes. She explained about the immunity. And this virus transmitted to human through the bite of infected mosquitoes, that is Aedes aegypti or the Aedes albopictus. And access to proper medical care lowers fatality rates. This illness found in tropical and subtropical countries, mostly in urban and semi-urban areas. And dengue infection causes spectrum of disease from subclinical infection to severe dengue. Severe dengue is the leading cause of serious illness and death in some Asian and Latin American countries. So the global incidence of dengue has markedly increased over the past 2 decades. About half of the world population is now at risk of dengue, with an estimated 100 to 400 million infections occurring each year. 1 in 4 patients are symptomatic. In the past 20 years, dengue has spread rapidly around the world. From 2000 to 2019, it is documented a tenfold surge in reported cases, from 500,000 cases to 5.2 million cases. Since then, dengue incidence has surged with over 12.3 million cases as of the end of August this year. It is almost double the 6.5 million cases reported in all of 2023. So, what are the factors associated with an increase in risk of dengue epidemics and spread to new countries include early start and longer duration of dengue transmission seasons in endemic areas. That means prolonged seasonality. And also changing distribution and increasing abundance of vectors, that is Aedes aegypti and Aedes albopictus, and also due to consequences of climate change and periodic weather phenomena such as El Nino and La Nina events, leading to heavy precipitation, humidity, and rising temperature. Those are conducive for mosquito breeding or mosquito reproduction and virus transmission. So the dengue cases will go up. And also changes in the circulating serotypes within a country affecting population in immunity. I think Dr. Gabriela explained that very well. And also the fragile health systems also matters, and movement of people who are infected and goods that could carry the mosquito vectors are some of the factors that would lead to dengue epidemics. So I'm working for a National Dengue Control Unit in Sri Lanka. So I'll give brief count on dengue in Sri Lanka. We implemented a national action plan from 2019 to 2023 with two main objectives. One is to achieve the incidence below 100 per 100,000 by the year 2023. And the other one is to reduce the case fatality rate below 0.1% by the year 2023. And you all can see the figures. And while we successfully reduced the case fatality rate, the incidence target was not fully achieved. Currently, we are finalizing the next national strategic plan for the prevention and control of dengue from 2024 to 2023. The key goals of this new plan are to reduce dengue-related fatalities to zero in line with the global targets and bring the incidence of dengue down to less than 100 per 100,000 by 2030. This slide presents over 2 decades of data on dengue incidence and case fatality rate. It clearly demonstrates the establishment of dengue as a high-level endemic disease in the country, Sri Lanka, accompanied by the marked reduction in the case fatality rate over time. Actually, we had a huge outbreak in 2009, and at that time, the case fatality rate was almost 1%. But with all the interventions, training of clinicians and the infrastructure of the hospitals, has gone down with all these interventions, the case fatality rate has gone down steeply over 4 years. And it is maintained at lower level since 2015. And also this slide highlights the disparities in dengue incidence across different districts. So it emphasizes the need to prioritize vector control activities, especially focusing on high-risk districts to reduce the disease burden more effectively. So we have to go by the risk-based approach. We experienced 2 dengue outbreaks annually coinciding with the 2 monsoonal rains. Therefore, it is crucial to implement targeted control measures, both before the onset of the rainy seasons and during the outbreak periods, to effectively manage and reduce the transmission. This highlights the most affected age groups, particularly those in the economically productive age range. That is, the percentage is around 60 to 64%, and the school-age children, nearly 26%. This slide shows the circulating dengue virus serotypes from 2022 to 2024, with the type 3 currently being the predominant serotype. We have done few samples in this year, but the predominant serotype is type 3. These are the dengue death details in Sri Lanka. This slide presents the death data from 2022 to 2024, clearly demonstrating a reduction in the case fatality rate. In both 2022 and 2023, the number of affected males and females was nearly equal, like 48, 52%, something like that. Females are a bit higher. But however, in 2024, there is a noticeable increase in cases among females. So we have conducted a death review very recently, and we discussed 4 cases. And we noted that the bleeding PV is one of the main factors for these deaths. This slide represents entomological surveillance data that clearly identifies high-risk premises like government institutions, schools, other educational centers, religious places, factories, construction sites, so on. So therefore, it is essential to focus our control efforts on these areas to effectively mitigate this disease transmission. This illustrates the vector availability across different health administrative areas. The potential for disease transmission is notably high, particularly in areas where Aedes aegypti is highly prevalent. That is marked in red. These are the disease control strategies. Integrated vector management is a crucial strategy for controlling and preventing dengue. It's important to apply vector control measures that are tailored to the local context, using data from the disease surveillance and from the entomological surveillance. And also, we do have a disease surveillance, web-based real-time disease surveillance platform. So case-based field investigations and the vector control applications are done using those data. And the communicating dengue risk to the public in timely manner is crucial for getting the community involved in activities that reduce the mosquito breeding sites. Collaboration among various sectors and engaging in all relevant stakeholders is vital for tackling this problem effectively. Moreover, strengthening the workforce's skills in outbreak management, along with the improving clinical care, strengthening health system, is important for effective outbreak control and patient management. And accelerating research and development is another critical strategy for creating sustainable methods for controlling vectors and developing effective treatments or the vaccines. These are the research projects going on in Sri Lanka. We are doing the Wolbachia method, it's a replacement method, and the sterile insect technique is a reduction, population reduction method, and the spatial repellent project. As Dr. Gabriela explained, WHO recommend there are 2 WHO recommended vaccines, but in Sri Lanka we have not registered these 2 vaccines yet. Thank you.
Thank you, Dr. Anoja. That was such an excellent presentation, and really from both of our experts, we're grateful for that groundwork. You know, we could hear from both of you that the burden of dengue in particular and arboviruses in general is increasing, and I'd like to know what you think is truly contributing to this increase. So perhaps a 2-part question. One is, are we seeing an increase in other arboviruses the way we are in dengue virus? Dr. Gabriela, I was very struck by your graph showing the increase between 2023 and 2024. And then the second part of the question is what explains this increase? Is it truly the combination of climate change and human mobility? Is it possible that we're diagnosing more cases now than we ever did before because of diagnostic test availability? Is there anything else that could explain this increase? So maybe Dr. Gabriela, we could start with you.
Yeah, thank you for that question, Amir. And I think that we're seeing sort of an explosion in dengue. 2024 was a huge year for dengue, as I showed you on the graph for the Americas and then on the map for the world. We're also seeing increases in other arboviruses, but I think sort of dengue has won the prize in 2024. And in terms of the reasons behind it, Dr. Dirasinga mentioned some of them, but I would like to focus on 3. One is climate change that is helping mosquitoes thrive. Again, dengue is a mosquito-borne virus. it requires warm and humid environments, and this has been a very humid and warm year. And it helps both increases in dengue in areas that have had dengue before, like Brazil, for example, had the worst outbreak ever in history, and they were responsible for 9 million of the 12 million cases reported in the Americas. So most of them come from Brazil. But we're also seeing expansion to new areas where we had not seen dengue before, like in Lima, Peru. Traditionally, they didn't have dengue outbreaks, and they had a huge outbreak last year. So climate change is one. Two is that dengue is cyclical, and we tend to see epidemics every 3 to 5 years. So as we both discussed, dengue is caused by 4 different viruses. So during an outbreak, there is population immunity that is built, but it only provides short-term cross protection against the other serotypes. So when immunity starts coming down, then you get another outbreak. And third is travel. I think during COVID, there was less travel, and that actually helped reduce dengue transmission. But now travel is back up, and it's humans that help the virus move around.
No, that's a very clear answer. A quick follow-up question that's coming from some of our audience members is specifically about the serotypes that you just raised. Do you see homogeneity in those serotypes that are involved with outbreaks? So, for example, when there's outbreaks in the Americas, is it all serotype 3 as you presented?
Yeah, I mean, one important change in dengue transmission is that now we're seeing multiple serotypes circulating, but there is usually one serotype that dominates. In the 2019 outbreaks in the Americas, it was mainly dengue 2, and we're seeing a change now, and it's mainly dengue 3 being transmitted in the Americas. In the case of Puerto Rico, we had the last large outbreak was in 2012. That was dengue 1. After Zika, we didn't see a lot of transmission. And now we're seeing mainly dengue 3, but also dengue 2 and dengue 1 circulating. And there was a question on the chat about the cases in California, and those are dengue 3 cases.
No, thank you for that. You know, for our members of the audience, one of the reasons why these different serotypes can cause clinically significant diseases is because if, for example, a child gets infected with one serotype at an age, they may have a silent infection. Dr. Anoja mentioned that many patients with dengue may be asymptomatic, or they may have fevers and a rash, but then the next time they get infected with a different serotype, there is a process called antibody-dependent enhancement, which actually causes more severe infection than would have otherwise been seen for the initial infection. So that subsequent infection sometimes is more severe than your original or index dengue infection. I want to turn it over to Dr. Anoja. You mentioned a very interesting and novel technology that's being tested, that's being explored and used of Wolbachia replacement. I'm wondering if you can explain to us a little bit about how Wolbachia replacement works to prevent transmission and how you've all been using it or studying it.
Thank you, Amir. Actually, we are currently conducting Wolbachia research in 2 medical officer of health areas in the Colombo Municipal Council. Medical officer of health area is the smallest health administrative area, and the Colombo Municipal Council has the highest population, and Aedes aegypti is the most prevalent vector. That's why we have selected that area. And Wolbachia infected mosquitoes were released in 2020, but it was interrupted due to the COVID infection epidemic. And then again, they have continued it for another 6 weeks in 2021. We now conduct annual checks to assess the frequency of Wolbachia in mosquito population. This initial study was done to assess the feasibility of introducing the method to the community, to check the community acceptance, because we are releasing mosquitoes to the environment. So we had a huge campaign to, educate the people regarding this method, what is happening with this release of mosquitoes. And now we are planning to expand this to entire CMC, Colombo Municipal Council area in the near future. We are looking for the funds to expand that program.
Well, great. How are you going to be able to measure the success of this, sort of novel vector control strategy? Do you look at cases, or do you look at what proportion of mosquitoes are competent to transmit dengue, which is, essentially where this intervention is stopping. It's stopping the ability for these mosquitoes to replicate, to predict, to transmit the infection?
Actually, we have not analyzed all the data yet. With 2023, we had a collection of mosquitoes, and we have sent it to the Monash University. According to their data, it's the frequency of Wolbachia was, if I remember correctly, 28%. Because we have selected a small area of CMC area, because mosquitoes may come from the other adjoining MOH area, medical officer of health areas. But mainly to assess the feasibility, we have done that. We see the reduction of cases in that particular area. We have not statistically analyzed those data yet. But again, we are doing a sterile mosquito technique. We have done small scale field trial that is for Aedes albopictus. Actually, we had promising results. There was a reduction of mosquitoes for 6 months in that particular area. It's only the Aedes albopictus prevalent area, and it's surrounded by a paddy field, so we could do that research very well. Currently, we are planning to scale up that research as well and looking for the funds.
Okay, well, we wish you luck. These are really important measures that are being tested, and hopefully, if successful, can be implemented in many parts of the world that urgently need these interventions. We also have a lot of questions about vaccination, and in particular, dengue vaccination. So we know that many arboviruses have existing vaccines, like the yellow fever vaccine is kind of most notable in my mind. Let me turn to you, Dr. Gabriela. You are an expert in dengue vaccine development and testing. What can you tell us about the state of dengue vaccination? How have the different formulations varied or differed from each other in their effectiveness, and where do you see the future of dengue vaccination going?
Yes, and I would like to go back to what you were mentioning about antibody-dependent enhancement, because it's very important that a dengue vaccine provides protection against all 4 dengue serotypes. And what we have learned from the natural history of dengue is that the second dengue infection is the one that has the highest risk for severe disease. And the reason for this is antibody-dependent enhancement. So the antibodies that are developed during the first infection to fight the first virus, when a person is infected again, they actually help the virus get inside the cell, and that results in an increase in viral load and an increase in the risk of severe disease. So for vaccines, if a vaccine does not provide protection against all serotypes, does not have balanced protection, the person gets vaccinated, and when they get infected with dengue naturally the first time, if the vaccine does not protect against all serotypes, the same phenomenon can happen, that the vaccine works as the first silent infection and then could make the second infection worse. And this is what happened with Dengvaxia. It was mainly a dengue 4 vaccine, provided some protection against dengue 4, but did not provide protection against the other serotypes in persons who were seronegative, who had never had dengue before. The vaccine was safe and effective among persons who had dengue before or seropositives. And it was recommended by WHO among seropositives, recommended by ACIP among persons who had a confirmed previous dengue infection with a laboratory test. So this has really complicated logistics for vaccine implementation, as you can imagine. It has been implemented in Puerto Rico. CDC evaluated all the IgG tests available and determined which ones in combination actually provided good enough sensitivity and specificity. So the program for vaccination has started in Puerto Rico. Again, the vaccine is only for persons who reside in an endemic area and who have had dengue before. And the next dengue vaccine was developed by Takeda. It's called Qdenga, and it was recommended at the end of last year for areas with high transmission intensity. The vaccine does not require a pre-vaccination laboratory test before administration, but the recommendation from WHO is very clear to use it in areas with high transmission intensity. The company has to continue doing studies post-licensure. So they're going to be conducting a phase 4 trial to understand more the safety and efficacy of the vaccine for dengue 3 and dengue 4. In the trial, the vaccine did not show protection against dengue 3, and there were very few dengue 4 transmissions, so it was not possible to have conclusive results. So that is ongoing, and we're looking forward to hearing about those results from the company. The last dengue vaccine is the NIH vaccine. It was developed by NIH and has been evaluated by the Instituto Butantan in Brazil. The 4.5-year follow-up data from that phase 3 trial was recently published, and it's showing good efficacy for both seropositives and seronegatives. They only had transmission of dengue 1 and 2 during the trial. So they have provided data for those two serotypes, but still no data for dengue 3 and for dengue 4. So it just talks to the challenges of evaluating dengue vaccines, that you need to have a trial that is lucky enough to capture all serotypes circulating, and you need efficacy for people who have had dengue before, for dengue naive, and for the 4 serotypes. So more challenging than vaccines for other conditions.
Oh, thank you for that very clear explanation. You know, we have a question in the chat. Dr. Anoja, can you comment a little bit about why their dengue vaccines have not been rolled out or made available in Sri Lanka? Does it relate to some of that complexity that we just heard about?
Yes, and I think the Takeda vaccine, they are conducting trials in Sri Lanka as well. So we have not published the data yet. So though they have produced the dossier to National Dengue Control Unit, the data is not enough to, the register the vaccine. And also now that it says, I think Gabriela mentioned that it is more effective for the other types, not for the type 3. So currently we are having type 3 serotype. That is not the main reason to, the register, but it is very complex, as explained Dr. Gabriela. We have to, analyze everything and register these vaccines before, because there's a past bad experience with the other vaccine, which explained that. Dr. Gabriela explained that very well.
No, it's a good reminder that even when a vaccine is effective in a scientific research study, it's really the vaccination on a population level that is what we need, and the complexity with knowing when it's effective and when it's potentially contributing to antibody-dependent enhancement has really made vaccine implementation for dengue a challenging task. So we applaud everyone who's working on that important work. We do have a question in the chat about the vectors We've seen with some arboviruses and some, vector transmitted infections, new vectors emerging. Is that something that we may see with some of the arboviruses as well? Different species of mosquitoes, for example, emerging to transmit infections like dengue and Zika and chikungunya. Dr. Gabriela, why don't we go with you on this one?
Yes, well, for dengue, the most efficient vector is Aedes aegypti. Aedes albopictus can transmit dengue, but it has been less commonly associated with large outbreaks. There are other species of Aedes mosquitoes that can transmit dengue, but maybe less common in urban areas, more in perisylvatic areas or in rural areas. But I wonder if Dr. Anoja has more specifics on other vectors. But Aedes mediovitatus, for example, is another Aedes species that exists in Puerto Rico. We have suspicion that it can transmit dengue because it has been shown in the lab as being able to transmit the virus. And we're currently planning evaluation in the field to understand if it's playing a role with transmission.
Actually, in Sri Lanka, we don't see other Aedes vectors transmit dengue. Only the Aedes, there are other Aedes mosquitoes, but Aedes aegypti and Aedes albopictus is the vectors that are important for dengue transmission. But I think in other countries, there are other Aedes species. They think that transmit the dengue in their country, like in French Polynesia. They do have other Aedes species. They think that those species transmit the dengue. But in our country, we do have only those two vectors. As you very correctly said, Aedes aegypti is the most efficient vector, and they can transmit the disease very rapidly, not like Aedes this.
That's excellent, and I'm looking at the time, and I can't believe we're already approaching the top of the hour. I'm going to ask one or two more questions if we could fit it in before turning it over to both of you for final thoughts. We have a great question in the chat asking about what the situation is in the continent of Africa, and even though I know that's not where either of you work, I would be interested to hear. What are the supports available for public health authorities? So we know that in some less resourced areas, so for example, in the Asia Pacific regions, in the African continent, it's been challenging to get widespread vector control measures implemented, and what directions for implementing research and advancements in say vaccines and vector control in some of these lower resource settings, such as in sub-Saharan Africa and maybe the Asia Pacific regions. Dr. Anoja, any experience or discussions on your end about either of these areas?
Actually, I don't know much about the African region and the African region, but I have looked at the dengue dashboard of WHO. It shows that there are thousands of cases from the African region and also from the Western Pacific region. But I don't know the setting in the African region.
No, it's true. And especially we can almost imagine that there may be underreporting of cases because of the availability of testing and some areas may not be as widespread. How about with you, Dr. Gabriela? What are the kind of coordinated efforts on a larger scale that the CDC and other public health agencies are taking part in?
Yes, no, I think what's going on in Africa with dengue, it's a really important question. And as Dr. Anoja was saying, we hear more and more reports of transmission from different countries in Africa. And CDC and PAHO have been working in the Americas to really set up the infrastructure for dengue diagnostics. And There is a network of labs called RELDA, and most of the labs, if not all of them, have now the capacity to do molecular testing for dengue, and half of them have the capacity to do sequencing. And this is not the case for countries in Africa. We have been in discussions with the Africa CDC to see how we can conduct first a needs assessment to see the type of equipment that they have and the type of testing that they're currently doing with arboviruses, and then to provide training and technical assistance so that we can strengthen the laboratory infrastructure. And it's important for several reasons. For the vaccine recommendations, we will have to better understand burden of disease in the Africa region, because it's really hard to implement recommendations for high transmission areas if we cannot really identify them. So one aspect is conducting diagnosis for acute dengue with molecular testing and IgM, but then also being able to conduct serosurveys to determine past infection and identify the areas that are at the highest risk. And I just want to end by saying that we have worked specifically with Burkina Faso to set up sentinel sites and conduct arbovirus testing. And last year, they reported the largest dengue outbreak in the region, but it's because they have the capacity to diagnose and identify dengue. And before that, in many cases, dengue was misdiagnosed as malaria. And that is happening in several countries. So I think working on strengthening laboratory capacity and also on conducting surveys to determine the areas with the highest transmission intensity is going to be very helpful for vaccine implementation.
No, thank you. That's such an important reminder as well that the clinical presentation of many of these viruses overlap. Fever, a rash, severe illness, and laboratory abnormalities can be the same in many of the same in very different infections. Dr. Anoja, I'm going to try to fit in one last question before I ask you all for a summary. You mentioned the progress in Sri Lanka on dengue virus. It has really made incredible achievements in reducing the mortality. What do you think explains that success there, and how, with an eye of how can we translate that to other parts of the world?
Actually, Sri Lanka has a good network of hospitals, and so people can easily access them for treatment. Their hospitals have necessary equipment to manage dengue patients. Actually, we need portable ultrasound scan, hematocrits, and monitors. All those are available to manage the dengue patients. We have established a high dependency unit in hospitals to manage the dengue hemorrhagic fever patients. And also we have trained the clinical staff, so they have good level of skills to manage the dengue patients. And also we have regularly strengthening the health system. We provide all the necessary equipment to the hospitals. But we need to strengthen primary care hospitals to reduce the burden on major hospitals, because all the patients, they go to the base hospitals and above. Those are bigger, the major hospitals. But the challenges are, though we are educating people, because we are trying to bring down the case fatality rate to 0 by 2030. So it's a huge task. So we are educating the people to come to hospital early after 48 hours of fever. If the patient is a pregnant woman, she should come on the very first day to the hospital, because they can easily go into the complications. And those are the few problems. And the major problem is keeping continuous commitment from different sectors and active community involvement. Those are the challenges.
No, well, that's with all of those challenges, I think you've demonstrated and discussed how the close collaboration between public health authorities and clinicians really is key to that success, and it's an excellent summary. I think now we should wrap up. If there's any one or two messages that you would love our audience to remember and to know about this topic, and I think just by virtue of the participation and the questions that we haven't had time to address in the chat, we may need to have a part 2 session in the future because it's such an important topic. But maybe Dr. Noja, I'll start with you and then end with Dr. Gabriela. What are just the final message that you would love the audience members to remember about this issue?
Now this dengue is spreading all over the world, and vector is very efficient. So I agree that we have low case fatality rate, but with increase of cases, in future, case fatality may go up. So we have to, bring down the caseload anyhow. I mean, by controlling we have to apply the suitable vector control methods for the relevant areas, because there are so many vector control methods. So we have to select the suitable method for that particular local context.
Thank you. And Dr. Gabriela, let me give.
Sorry. And also it's the responsibility of general public to keep their premises free of mosquito breeding places, not only the houses, but also the working places, schools, and those places, because those are the high-risk premises, especially in Sri Lanka. I think it's same for the other countries as well.
Yes. No, good reminder. Dr. Gabriela, let me give you the final word here. What can you tell us that we should remember about this topic?
Yes, I am optimistic about the future for dengue prevention. We have had decades of really hard mosquito control. Insecticide resistance makes it really difficult to control the mosquitoes that transmit dengue. And now we have a vector control intervention that works, that has shown that it's efficacious in 14 countries where it has been tried, Wolbachia replacement, and that can be a sustainable strategy to reduce dengue. And we have dengue vaccines. The Takeda vaccine is a 2-dose vaccine. The NIH vaccine is a 1-dose vaccine. So I think that we can really make a difference with the available tools. And different sectors have to play their role to change the way that we do dengue prevention, but I am very optimistic that we're at the brink of a new era.
Well, we're going to have to feed off of your optimism, Dr. Gabriela, as we hear about the not just dengue, but many other viruses on the news with each passing day. We really salute and applaud both of you for your important work in 2 important endemic areas for dengue and other arboviruses. I'd love to take this opportunity to remind all of our audience that our recording of today's event is posted on the Harvard Global Health Institute YouTube channel, and we put that link in the chat. You could find a list of other events that we've hosted in the past on our website. We are so grateful to all of our attendees for coming and listening to this topic and supporting our work. We're particularly grateful for our 2 expert panelists for sharing their wisdom and their expertise on this topic. And we are looking forward to seeing you all again at the next session of our speaker series. Thank you, everybody.